Welcome to The Sterile Room. This is a podcast geared toward all general surgery residents to discuss a myriad of topics ranging from choosing a fellowship, performing a COCA maneuver, and to managing one's expectations during a grueling 5 years of residency. The goal of this podcast is to provide listeners with another line of education, but also, and more importantly, to discuss topics that are deemed taboo and hopefully sterilizing them. Thank you for tuning in. Hi guys, this is Paul T. I want to thank you again for tuning in for the first episode of The Sterile Room. We will be discussing fellowship, most notably trauma and critical care, with co-creator and host of Behind the Knife, Dr. Patrick Georgoff. Please enjoy.
For today, we're actually honored. I'm honored, and you guys should be too. We got the Dr. Patrick Georgoff coming in today and discussing trauma, acute care, and surgical critical care fellowship, and giving some advice about that. Just some background in case you guys were living under a rock for the past few years. Dr. Georgoff went to medical school at University of Pennsylvania, did his residency over at University of Michigan, as well as a fellowship, surgical critical care there. And then he went on to do his trauma fellowship over at University of Texas Memorial Hermann Hospital, aka Red Duke Trauma Institute, Texas. And like I said,
the big T.
The big T. Excellent.
Jump in.
Yeah.
Thank you for that very, very kind introduction. It's great to be spending time with you today. And,
Sure.
I've enjoyed learning about your past and your dedication to the field, and I'm really excited to see what you do moving into the future. And I'm very happy to be on with you today and to hopefully say something useful about this whole process when it comes to thinking about fellowships and the next steps in your career.
Yeah, right on. Thank you so much. Appreciate that. Why does someone do a fellowship?
Yeah, so that's a great question. So first of all, if you look at the numbers across the United States, the vast majority of general surgeons who graduate from a general surgery residency go on to do a fellowship. And, the question is why. And I think at its core is you want to be the best that you can be. And so you want that additional experience and exposure to be the most ideal surgeon you can be in that specific field that you're going into. But there's also a lot of different expectations, market pressures, etc., in this hyper-specialized world that we're living in. I mean, the days of, community general surgeon, except for in the most rural areas of the country, is gone. And so more and more surgery has become a specialized field. And that even includes things like trauma and critical care as well, which is a little bit newer. And so people want to be competitive. They want to get that job that they want and live in the area that they want. And so fellowship is potentially one way to be able to do that.
Well said. No, I 100% agree with you in that. And that's actually sort of the advice I've been getting around from other attendings. Next tidbit is, so trauma in surgical critical care, it's, how competitive is it? Is it, I know it's not pediatric surgery fellowship level, but, how difficult is it for someone to get into a fellowship spot?
Yeah, so that's a great question. It used to be, if you look 10 years ago, it wasn't competitive. A lot of the fellowships are going unfilled. And I'm sorry, I don't have the numbers in front of me. Maybe, Paul, you might be able to add these in after the fact, is the number of folks applying to trauma and critical care, acute care fellowships. Competitiveness has gone up. It's gone up significantly for some key centers as well. So some of the kind of the bastions of trauma, surgery, and critical care, they're seeing massive number of applicants. So most folks applying should still be able to get a position regardless of where. But as you look for those upper echelon type institutions, it's becoming more and more challenging, again, especially when compared to 10 years ago. And so I would, again, love to pull that data up, but it is, where was I at? It was either AAST or East or one of the conferences, and it is a straight 45-degree line going up in terms of the number of specialty. It really helps to form it into something better than previous iterations.
So I just did a hard search right now. Looks like a number of residents is 20% increase from 2015 to 2018. So like you said, there is a upward trajectory going for that. The next question is, what makes a good candidate? Obviously, we all remember, ABSITE, research, letters of rec. What I'm hearing a lot, at least from others, is it's really who you know. Is that true?
Yeah, unfortunately, to some degree it is. That's not everything. But it's a small community. And if I pick up the phone and call, one of my best friends over at XYZ institution and say, Paul is an absolute stud, you can even forget about anything or anything else he puts in his CV and his application. I'm telling you from experience that he's an absolute stud and he's going to do phenomenal things for your institution. That's a huge piece of it.
Right.
And that's, in a lot of ways, it's unfortunate, right? Because it shouldn't be about who you know or even maybe necessarily the institution that you come from. But that is only one part of it. Everything you mentioned is important too. Those letters are important. Clinical performance indices, the number of cases you've done, I guess maybe ABSITE score. I think, people do like to see a decent score. I don't know how important it frankly is. I think a lot of the differentiating factor is also the extra stuff, right?
Right.
Have you done a bunch of research? Have you innovated in some type of way when it comes to entrepreneurial type activities? Are you a master, educator? Have you won teaching awards? Have you worked on quality improvement projects at your institution? That's a big differentiating factor because everyone can talk about coming out of their respective program and say, I'm a really great surgeon. I've worked my butt off to be, as high level as I possibly can be. And you're going to have lots of cases. You're going to meet all the criteria. So then what differentiates you from the next person? And again, I think probably looking back at it, biggest things are those letters and who you know and the extra work that you may have done that makes you, more unique and or marketable for that fellowship that you're applying to.
Next question. What should we look for in a fellowship? Obviously, we already kind of went over that stuff, but more so, are we looking at operative trauma numbers? Because, I think a lot of what I've been hearing and, what we're afraid of is that critical care year, we don't want to lose, our surgical skills. Is that something that we need to look into if we can take surgery call during those critical care months or if we can get, good operative cases?
Yeah, that's a really good question, and I think we'll spend a little bit of time talking about this because it's a bit more nuanced than other fellowships. So let's say you're going to go to, you're going to see cardiothoracic fellowship, or you want to do transplant. There are different features of each of those fellowship programs that individual is going to apply to, but those differentiating features are only so different, right? Those fellowship programs, by and large, are very, very similar. Certainly, you want to do an aortic root or something like that, or move on to pediatric. Pediatric cardiothoracic surgery, certain programs are going to be better for you than others. But by and large, that degree and differentiation between programs is less so than when you compare most of the other fellowships we talk about to trauma and critical care. So and that's because it's new, and that's because it's 1 year, it's 2 years. That's because some places are heavy on trauma, not on EGS, more heavy on critical care, not on trauma. Right. And so the variation is huge. And so the most important factor you need to think about when you're applying to fellowship is, what do I need as an applicant, as a surgeon? What do I need to fill out my experience to make me the best surgeon I can be? You asked why we go to fellowship. We go to fellowship to be better, right? To be the best provider that we can possibly be. So you need to fill in those holes. You need to plug those holes where maybe your experience is not so strong. Now, to be clear, the only part of an acute care fellowship that is board certified is the critical care year, right? So the only ACGME board certified portion of this whole kind of career we're talking about is the critical care year. And that is a 12-month year with at least 9 months of intensive care rotations, usually across a variety of different units. And then you have the 3 months of electives. So that's that's the 1 year. And the other year is oftentimes the focus, more of a surgical focus on being focusing on trauma surgery, emergency general surgery, and being a quote unquote like junior attending with maybe admitting privileges, call privileges, etc. Now, so some of the programs are 1 year, some of the programs are 2 years. And so that's a huge, differentiating factor between them. Some of the programs you take surgery call to varying degrees during your critical care year, and some programs you don't. And then when you're talking about that non-critical care year, Some of those years are, again, maybe very heavily focused on trauma or more heavily slanted towards emergency general surgery, or more focused even on autonomy, in saying that our purpose for this year is to essentially pay you nothing, make you work like an attending, and you gain that experience, right? And you have lots of support and safety mechanisms behind you to grow and be safe, and feel comfortable then, being let out into the world as a trauma and acute care surgeon. And because that's a little bit different, right? I mean, let's say your first night on call as an attending, you're never, or hopefully you're not by yourself at your job, truly by yourself. But it's a little bit different when you're in the middle of the night and someone comes in with a gunshot wound to the heart than if you're planning, your next Whipple that's going to be an elective surgery during the day, right? You have that latter example is you're going to have lots of support and time to think about it. The person who comes in with a gunshot wound to the heart is going to die in front of you in minutes. Sure. You can call your partner in and all that, but it's a little bit different. So this idea of adding an entirely extra year of training to your entire year of training to what's already been a long course, to say that I'm going to play attending but not get paid like it's, some people that makes sense and some people it doesn't. There's definitely pros to it and there's definitely cons to it. So you have this highly variable fellowship options, and so you need to think about where you fit into that. And I would say that by and large, the most common setup is a 2-year fellowship, with the first year being critical care and the second year being surgery focused. I think that's probably the most common in the way things are going. Now, I mentioned that, the critical care year is ACGME certified. You take your boards and everything and get your board certification. The acute care surgery year, to the extent that that's become codified, is through the AAST certificate. Now, to confuse things even more, some programs may offer a AAST certificate, which you get after the full year and reporting your case log and taking a written test to say that you are certified in acute care surgery. And some programs don't. So then the question for that is, it's another differentiating factor. Does that matter? At this time, it doesn't. I'm going to go ahead and say it does not matter. It really, to have the AAST certificate doesn't matter. You got to have that board certification in critical care. That's, given, but the certificate doesn't matter. I mean, it's not that big of a deal to do it and get it. And if you can, then by all means do so. But at least right now, that is not a differentiating factor. So if you went to a program that's super heavy, so then, like I said, we're going to fill in those holes, the gaps in your training. But then the next question you ask yourself is, well, what do I want to do with my life? If you don't want to work at a major, level 1 or level 2 busy trauma center, then getting a whole bunch of trauma experience is going to be useless to you. It's not useless, but it won't be as high yield. Let's say you're really not that interested in critical care. You just want some basic critical care skills to do mostly, surgery-centric type, practice. Well, that matters too. Or you want to be a general surgeon, more of a general surgeon type, focus in more of a rural area, and you need to hit all of the, all those check boxes. You may do that. So
that's awesome. Yeah, and you kind of I had a follow-up question to that, because the next one I was going to ask is, should one do the 1-year critical care versus the 2-year traditional one that you were just discussing? And I think you've went over that pretty well. I was just thinking, maybe think about this scenario then. Brand new grad finishes up, obviously hits all their numbers, their volume is comfortable. When should they do that critical care year? Like, should they go into practice, still hone their skills, like you said, that junior attending type role, and then perhaps do a critical care fellowship down maybe 1 or 2 or 3 or 4 years down the road after they've honed on some of their surgical skills?
Yeah, that's a great question. And everyone has their own, needs, and, their lives are heading in different directions at different times. And so it's hard to answer that question because everyone's going to be unique about it. But I would say, if you're able to, you should do your fellowship once you're done with your training as soon as you're done. Because you're just exponentially less likely to go ahead and do it once you're out in practice, making money, doing whatever your family's doing, XYZ, you don't want to move, etc. I think there's no reason that you shouldn't go straight through and do that fellowship and get it done and then go start your career, because that's more of a kind of a halting type process if you're saying, well, yeah, I'm going to plan to do it, but right now I'm not. And so I would highly recommend that you, once you finish general surgery training, that you go ahead and do a fellowship. One thing that I did a critical care fellowship during one of my research years at the University of Michigan. And that was because I was thinking about being a vascular surgeon, but I loved critical care. And so I said, well, I'm going to do critical care in a CT, work in a CT ICU and be a vascular surgeon. And so I'm going to do this critical care year during one of my years of research, and I'm going to apply to vascular surgery to be all set. But during that time, I decided, I had a change of heart, and surprising how I could ever think otherwise, to not be a trauma and acute care surgeon because I love it so much. But decided I was going to go down that route. And trying to secure a single year of non-ICU training was not fun. The folks at the University of Texas were amazing and very accommodating. Lillian Cow, Brian Cotton, to get me there for an extra year. They really just were fantastic and made some. They were very accommodating, and that was stressful to try to figure that out. And so I would not recommend splitting up your years. I'd recommend you either choose to do a 1 or 2 year fellowship at the end of general surgery.
Noted. And kind of we're finishing up here, which is great, making great time. When should they start really, getting all their ducks in a row?
Yeah. So, gosh, I don't know off the top of my head exactly the due dates. I don't remember what it is, because I know, we're interviewing now. This is springtime. I think your due match is in the fall. It's in October, November, and spring. You're interviewing in the spring. So, all right. So let's reset that. So I can say, when it comes to the fellowship process, in general, you're interviewing in the spring and summertime, and you're matching in the fall. And so, just like for residency applications, any other applications, you want to start thinking about this well in advance. And if you know what your career trajectory is going to be, then you want to start hanging out with folks at your institution that are trauma surgeons, that are intensivists, et cetera, and spend some time with them. We mentioned before the importance of letters and phone calls, et cetera, to get you to that fellowship. You want to spend some time with them, work on projects with them, do cases with them, et cetera, and sit down and say, hey, are you willing to be my mentor, like in a formal sense? Can you mentor me? I want to go into this field. I think you're a great surgeon, great person. Can you help mentor me? And the earlier you do that, the more of a relationship you build, and the more opportunity you have to build your resume for that specific application. Hopefully that mentor is a good mentor, and they say, hey, why don't you go off and do this asset and atom course? I'll help find the funding for you at our institution. Or why don't you help me write this paper on a trauma related topic? Or, hey, we're going to East. Come to East with me, and I'll introduce you to some folks I did training with at whatever institution that maybe you might be interested in going to for fellowship. So all those relationships really, really matter, and it helps you also solidify how you frame your career and what you love about it or don't love about it. As you go forward, when you spend time with those folks, you'll be able to develop some kind of clarity about your future too, and ideally get more and more excited about it too.
Yeah, and I know it's different. You start applying within your PGY 4, right, going to 5 year, and I know it's quite a bit earlier, because I was getting mixed up with one of my other chiefs, because I think they were earlier with cardiothoracic.
Right.
But yeah, no, totally agree with you.
There's nothing but helpful when it comes to this whole kind of process.
Absolutely. And the next kind of, like, all of these kind of run in together, but is it worth contacting the program directors, that you're interested at these programs early on, like shooting them maybe a courtesy email during your junior years rather than, is that too much? Is that being overzealous? If you're just like, hey, dropping an email, just want to say like, hey, I really enjoy your program, very interested in it, or is that just being annoying at a point?
I don't know. Per se, I think you want to be very self-aware, like you're suggesting, of not being annoying, because there's only so much that program director can do right at that time, because their hands are tied with whatever next process they're going through, the timing of these different things, etc. But on the flip side, it also doesn't necessarily hurt. So let's say you want to be in a specific city to maybe for family needs, you want to be there, and you really, really want to be there. Send an email saying, hey, my name is Paul, and I'm, going to be applying at such and such time, and I've got extensive family and other, or professional, whatever needs to be in that city, and you have an exceptional program, and I'm working extremely hard doing X, Y, Z to become the best applicant I can be. I just wanted to say hi, or, even better yet, if you can try to catch these people in person. Oftentimes that means conferences, even better. But I wouldn't rule it out. I wouldn't go crazy just emailing people though either. So, and I guess if you do it, I would have minimal expectations from it. And I'd have no expectations from it, just so you're not like thinking something's going to happen.
Strong words. And then I guess it's, and we kind of already went over it, and you've, like I said, you've covered everything I want to go over. My last thing was, and this depends where you're going, if you're going to big trauma academia or, smaller community hospitals, but overall, I guess, generally speaking, does doing a fellowship make you more marketable? I think that's...
So doing a fellowship 100% makes you more marketable, and I think that it's actually going to become the gold standard, the standard, or already has become the standard moving forward. I mean, there was a time period, acute care surgery is a new profession. I mean, it's roughly 20 years old or so. Before that, there were general surgeons who would have, maybe a community-based practice, would have privileges at multiple hospitals, and or even major trauma centers would have this rotating cast of characters taking call. Maybe the hepatobiliary surgeon one night, the breast surgeon the next night, covering, UGS and trauma call. And that's not ideal. Like we mentioned before, everything's becoming hyper-specialized. You want someone who's well-trained in particular areas, and there's no difference between, being well-trained in HPP versus well-trained in emergency general surgery and trauma. And so the model now for any decent-sized institution is to have an acute care surgery service, right? That's available 24/7, 365 days a year, that covers all emergent surgical needs, including trauma and emergency general surgery. Now, those fields or those groups, they look different. That's the other thing. You talk about fellowship being highly variable. Well, jobs are highly variable. How many partners are in the group? What kind of call schedule do they take? How much of it is trauma? How much of it is EGS? How many weeks are you doing in the unit? Very different, even within the same. You can say, I'm an acute care surgeon and do one thing here, and then say I'm an acute care surgeon and do another thing at a different institution. One of the other things I should mention there is how much elective surgery is happening. You have the opportunity to do elective surgery and build your practice as well, in addition to your role as an acute care surgeon. And so being a fellow, so going back to the original question is, is fellowship, doing a fellowship important? I think hands down, yes, because, that's the standard now. I think as you go out to more rural, the exception would be if you really want to be a kind of a rural surgeon, if you want to work in a smaller community, and kind of have a broad practice. And again, this includes not major trauma. And you are at an institution that may have, frequent, send a lot of patients to a tertiary or quaternary type centers. Well, then maybe you don't need to do a fellowship, right? If you're well trained at your general surgery program, you don't have to do a fellowship. You can, be very successful and happy doing that. Now, if you are going to go that route, I think that one thing you have to really, really carefully consider is who are your partners. Because you don't just do residency and then boom, you're done, or fellowship and boom, you're done with learning. Like it just can, it's kind of this like fellowship, yeah, I'm done. It's like, well, you're not done. The whole process, you're still constantly, learning and being anxious about, different cases. And, so that process, that learning process never stops. And so if you are, regardless of what your first job you're going to take, but you want to know, what kind of partners you have and what kind of support you have, that's especially true if you didn't do a fellowship and you're going to end up somewhere that's not a big center.
Yeah, a lot to think about. You raised some, amazing points. Appreciate you. So we're tailing in towards the end here, but this is not behind the knife, but we've got to do a high yield rapid fire summary. So just going from everything you said, why would someone do a fellowship, guys? If you're going to do it, you're just going to be the best surgeon you can be, fill the voids, whether it's operative or critical care.
Right.
You find that and you tailor it towards your needs and your own goals. So that's sort of what the theme is. It's kind of understanding where your timeline and trajectory is. And
and where you're going.
Exactly.
Right. What's the next after fellowship?
Absolutely. And next thing, it's an upward trajectory, guys. So, it's something definitely that's good for us, but also, too, it's getting more competitive. So definitely something to think about. And then 1 year versus 2 year and when to do it. I think the consensus is to do the fellowship immediately after. Don't try to put it off. And does fellowship make you marketable? It does. I think that's consensus. But once again, everything has to kind of align with your career goals and what you're going for.
Yeah, you did. What you didn't mention though too in this high yield is how fun fellowship is too. Fellowships are fun, but residency's fun, fellowship's fun. But man, trauma and acute care surgery is an amazing specialty. It's an exciting career. You do all types of gnarly stuff every day. It's super broad. And the fellowship itself is amazing. It's an opportunity to remove yourself from that general surgery grind where maybe you're doing, in the next month you're doing a rotation that you really just don't care that much about, right? It's not something that you're interested in. And instead focus on something that you're interested in. And man, is that invigorating. It's a lot of fun. And it makes it easy, to work your butt off and to read and to learn and to grow because you're finally doing exactly what you want to do. And, all the more reason. It's a long road. It's you're going to add more time on by doing that fellowship. But man, it's important to really round yourself out as a surgeon.
Absolutely. I guess that's why there's an F in fellowship for fun, right?
Yeah. Okay. There we go. I like that.
All right. Well, gosh, this is like I said, this has been a surreal experience. I can't tell you. I'm still kind of shaking here. I'm kind of glad we did this.
No,
this is truly awesome. I showed the email. I kind of boasted to all my other co-residents, and they were all super excited and stoked. So they're all going to be looking forward to this. And like I said,
you're very kind, and we got a lot more really exciting stuff coming from behind the knife, and that includes a lot of great stuff for the trauma and acute care surgeon too.
Oh yeah. Well, got a minute to spare. Can you do me the honor, though, Dr. Georgoff? Can you just tell the audience what they should do today?
Oh, absolutely. Dominate the day.
Gosh, that's awesome. All right.
Paul, it's been a pleasure.
That concludes this episode of The Sterile Room. Thank you for all the contributors, guest appearances, and of course, listeners. If you have any questions or concerns on the topic discussed on this episode, please feel free to reach out. And remember, folks, stay sterile.